Right. The next chapter which I am going to take, again this is also spin-off based and also some guidelines I will tell you in another presentation separately. It's very important for the exams. So how I have structured this is based on the questions that have been asked over the years in the last 5 to 10 years in DNB exams. I have also written down the questions for all of you. So just first we will start with the how we are going to approach the whole PowerPoint. So only reading spin-off. Spin-off is actually, outdated by at least 5 to 7 years, even the latest edition, when compared to the current guidelines. So it's always important that we do a guidelines based studying for the examination, but it is not possible for all the postgraduates because you're all busy in doing a clinical work also. So try to make it concise for all of you. So the questions asked in the last 5 years exam is ICMR guidelines for surrogacy in India, Surrogacy Regulation Act, all these things, commercial surrogacy. So about surrogacy itself, there have been a lot of questions which have been asked. Then complications of ART, short and long term outcomes, indications and methods of female fertility preservation, and pre-implantation genetic testing, different markers of ovarian reserve, indications of IVF and ICSI, GnRH egg antagonist, indications of IVF, protocols for IVF, factors affecting the IVF outcomes. All these are going to be extensively covered in this chapter. What is ART, components of an IVF cycle, how to prevent OHSS, role of IVF in unexplained infertility, OHSS, risk factors management. So I have given a separate presentation on OHSS itself because it's an important question which might be asked in many exams and even examiners are fond of this. ART is going to be a separate chapter. Ovulation induction is going to be a separate chapter, and the guidelines are going to be a separate presentations. The surrogacy guidelines, it's going to be a separate presentation. It's because it's very important all of you to know about it. Most of the other questions are answered in the same presentation. Now, so it's very important to know the definition. So definition is, according to the ASRM, is a method of assisted reproduction that involves combining the egg with sperm in a laboratory dish. All treatments which include the handling of the egg and the embryos, which includes IVF, GIFT, PROST, tubal embryo transfer, ZIFT, okay, IVF or ICSI. IVF or ICSI only we do for everyone. These all other things I have never seen them being done personally. These are all for theoretical purposes. Important thing is it does not include IUI and ovulation induction assisted reproduction. So keep it in mind because this will be the question which is asked in examination. You can boldly tell that it is involving a combination of egg and sperm in a laboratory dish, which we will not do. Egg will not be taken out separately unless and otherwise we do an IVF or an ICSI procedure. According to the spin-off, all techniques involving direct manipulation of oocytes outside the body. So, but usually we do not use this definition. Go for the ASRM based definition. Again, let's go to a small history. So, 1976, the first IVF pregnancy was done. It was an ectopic. And then the first IVF child, Louis Brown, was born in 1978. 1983, first FET baby was born in the US. 1986, first pregnancy resulting from oocyte cryopreservation. 1992, first ICSI baby in Belgium. So, now coming to the indications of ART, this was again a question. So, just read the names. Tubal factor, ovulatory dysfunction, diminished ovarian reserve, endometriosis, some uterine factors, male factors, unknown factors, combination of male and female factors. Other indications are fertility preservation, PGT to prevent heritable disease and gestational surrogacy. So, all these are the indications for ART. Now, other indications are fertility preservation, which will include oocyte and embryo cryopreservation. Now, coming to the PGT. PGT is pre-implantation genetic testing. There are 3 types in this PGT-M, that is for monogenic genetic disorders, A for aneuploidy and SR for structural reversal, that is for translocations and inversion. You just need to note the names because some examiners may ask, and one question has also come. See, basically what is it is, so this is the embryo, this is the tropectoderm, okay, for the blastocyst, that is the 5th day embryo, and there is a inner cell mass, okay, which will be the growing baby. So, the tropectoderm is where the implantation will happen. It will be a representative of the embryo. So, taking 2 cells or 3 cells from biopsy. Okay, biopsy of these 2 to 3 cells, what will happen is you can actually take out them and see whether they have any genetic problems or not. If you are targeting a genes and saying it will come in monogenic disorder, if you are not targeting anything, it will come in aneuploidy, and you can also see for any structural reversal, again for translocations or inversion. These two are done for already established genetic problems, and A is done for an aneuploidy. Now, going to the prognostic factors, maternal age is the most important factor. Decline in the response to the ovarian stimulation, fewer oocytes, embryos are decreased, and miscarriage rate increases, success rate comes down with the age. Then next comes to ovarian reserve. Again, low AMH has a higher negative predictive value for predicting poor response, but have neither sensitive or specific for predicting a pregnancy. That is, with a low AMH, one can tell that there is a poor chance of conceiving through IVF, but you cannot deny a pregnancy which is happening naturally, or you cannot predict the rate of a natural pregnancy. And you have to, the other prognostic factor is past reproductive performance or and diagnosis. So, as we know, the live birth rate decreases with the age. That is because the oocyte quality, the embryo quality, the implantation, everything decreases. There is a rapid decline if you see after 35-36 years of age. Then, what happens is live birth rate decreases and the miscarriage rate increases as the age increases, especially after the age of 38. So, it's very important for the women to conceive earlier. Now, another important prognostic factor is smoking. Other prognostic factors are hydrosalpinx. If there is hydrosalpinx, you can try a proximal tubal occlusion. Fluid aspiration, assure, all these things are, it's all given in SPEROF. You may not be asked in the exams. Just for a theory purposes, know that we only do a proximal tubal occlusion. We do not have a, we do not do a fluid aspiration or assure. You assure. Then uterine fibroids. Submucosal fibroids reduce the IVF success rate by 70%. Intramural myomas reduce it by 20 to 40%, and subserosal myomas have no adverse effects on the outcomes. Tobacco use reduces the chances of IVF success, and husband semen analysis is also very important. So, oligoasthenoteratozoospermia, all these things might actually be a prognostic factor in determining the success rates of your IVF. Now, going on to the pre-IVF evaluation. So, pre-IVF evaluation, what we can see, ovarian reserve of the lady, husband semen analysis, any infectious disease screening for both the partners, pelvic tuberculosis, if there is a strong evidence you can rule out. Then you should do a trial transfer, especially before the transfer, and you have to image the uterine cavity. Out of these, apart from the general investigations, that is complete blood count, sugars, thyroid, prolactin, all these things need to be done, and for the women ovarian reserve, and for the man husband semen analysis, and the imaging of the uterine cavity for the women. So, all these things are very much essential. Now, again there was a question on what is the process of IVF or the steps of IVF. There are 4 processes broadly. One is controlled ovarian hyperstimulation, second is oocyte retrieval, third is embryo culture, freezing with or without freezing, fourth is embryo transfer. So, IVF or stimulation protocols, there are 2 types. One is the agonist protocol, one is the antagonist protocol, then the mild stimulation and natural cycle IVF. One is the agonist stimulation is the long protocol, short protocol, ultra short protocol. The antagonist protocol is the single dose protocol, multiple dose protocol, and mild stimulation IVF and the natural cycle IVF. These are the 4 things. Okay. So, in the basically we commonly use the antagonist protocols. Just for the theory purpose, you can just go through all the things. It is definitely used practically also, but as a postgraduate, you should know just the names. That is enough, and a little bit about the protocol and the principles behind the protocols. Okay. Now, natural cycle IVF was the first thing which was developed. Okay. So, they carefully monitored the menstrual cycle with the serum hormones and vaginal sonography. When the dominant follicle is developed, they aspirated under oocyte. Okay. So, drawback is that in a natural cycle only one oocyte will be there. Okay. And they will be able to retrieve oocytes only in 50%. Other times we do not know whether there is an egg inside the follicle or not. So, pregnancy rate is also very, very less. Now, Agonist or antagonist injection. Why did they come up with the process of agonist and antagonist injection? That is because they have to prevent a premature ovulation. What happens is, you have, whenever there is a follicle that is growing, there is a estrogen that is increasing, that will go and cause a LH surge, and that will cause the ovulation, maturation, and then the ovulation, right? So, what happens is, you are going to have all these things are going to be entirely controlled in an IVF cycle by means of using an agonist or an antagonist, which will knock off the pituitary. Thereby, you will not have a LH surge for the ovulation, and all the follicles will be directly stimulated by the external hormones that are given. So, the mechanism of action, as I told you, the GnRH will increase the LH and FSH. The agonist will go and sit on the receptor, GnRH receptor, will initially cause the flare of an LH and FSH and decrease it after downregulation and desensitization. An antagonist will sit on the GnRH receptor and then it will block the LH and FSH. Okay. Now, GnRH agonist protocol, what will happen is, GnRH agonist causes an increase in the half-life, bioavailability, lipophilicity and prolonged receptor occupancy than the endogenous GnRH hormone. It will increase the LH and FSH hypersecretion, and in 10 days it will cause the desensitization of the pituitary and profound suppression of LH and FSH. So, the high incidence of attention deficit reactivity has been there in all these children, but absolutely we see no problem because we have long-term follow-ups of patients who have conceived with the agonist protocol. So, without the agonist, 20% there will be definitely a premature increase in LH, which will cause the follicles to rupture. Okay. Now, the mechanism of action is that there will be a flare, okay, of the FSH and LH, and then there will be an internalization of the agonist complex, and this will decrease the receptor numbers. Okay. So, once the agonist that is given sits on the actual receptor, what happens is, all these things after initial 2 to 5 days, all of the receptors will be decreased. So, what will happen is, loss of transfer of gonadotropin from a releasable to a non-releasable pool. Okay. And downregulation will persist after ceasing of the agonist also because of the internalization of the receptor. So, that is why, as we told in the previous slide, so there will be a flare of FSH and LH, thereafter the receptor gets internalized, and then there will be a decrease in the FSH and LH. So, this is very, 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 very important. Okay. Now, GnRH agonist. So, there are all these things are the GnRH agonist, that is leuprolin, goserelin, triptorelin, buserelin and nafarelin. So, the trade names are these and the doses are these as followed. Okay. Now, the protocol says the long agonist protocol which we use, usually it starts from the mid-luteal phase on the day 21 of the previous cycle. So, what we will do is, we will start the tablet progesterone or testosterone for 5 days from day 18. Then start giving the agonist 1 or 0.5 milligram per day from day 21. Then you continue till the day 1 of the periods. Okay. Until you get a period, you continue. And then we can check for the down regulation with E2 and LH. If you don't get a period, sometimes we do not get a period when you give the agonist. In that case, what we can do is, just after 10 days to 12 days after the starting of agonist, that is from day 21, 10 to 12 days, you calculate and do the E2LH. If E2LH shows that the pituitary is down regulated, then you can start your stimulation. Okay, then you can start the stimulation in the meaning that you start the gonadotropin injection. Once you start the gonadotropin injection, reduce the dose of the GnRH agonist to half and start the gonadotropin stimulation. And then you can do the TVS on 6th day, trigger the patient depending on the follicles and the numbers. Trigger is how the egg matures, and then do the pickup. So, these are the, as I told you, the 4 pillars. After that, you will do the embryo transfer, or you will freeze and then do a frozen embryo transfer. So, these are the this is the timeline of a usual agonist protocol. Okay. Now, patients who are having an endometriosis and adenomyosis or a fibroid, you can do a long agonist protocol. Now, advantages is, it has a scheduling flexibility, synchronous cohort, because all the follicles will be even in size when you start the agonist protocol. Because of the previous cycle itself, we are starting the agonist injection. Prevents the premature LH surge, allows prolonged stimulation, more number of oocytes, and ample embryos for cryopreservation. Disadvantages, we have to very important increased risk of OHSS, more duration of gonadotropin requirement, and duration of stimulation. It is very important to note these things, and you can, if you are asked in the exam, you can tell. Now, there are other protocols like short protocol. See, already theory is there. I'll just tell you the briefly. To start, why it is short? Because it starts from that particular cycle, index cycle, day 2 only, not from the previous cycle. It's almost the same. 0.5 for 4 days of agonist followed by 0.1 milligram per day until the day of trigger. Thereafter pickup and thereafter the embryo transfer. Then there is a micro dose flare protocol where you give an OCP for 21 days, that is a pills for 21 days, and you start the agonist injection only for 2 to 3 days, which will cause the flare effect. And then you give the gonadotropin. It's not given till the day of trigger, but only for 3 days. Then you give the trigger injection after the follicles are grown, and then do the pickup and the ET or the embryo transfer. Then ultra short protocol is there. Then stop protocol is there. When once the period starts, we stop the agonist. Okay. So all these things will help you in the, what these are the types. Only the names you can write in the exam. The microdose, flare, ultra short, all these things, names alone you can write, and just remember the concepts. As I told you, usual thing is the long protocol. The other things are modifications of the long protocol for an agonist cycle. Then the antagonist protocol. See, why there is a need for an antagonist protocol? Because once the agonist action starts, it's for a long time. Okay, and you cannot give an agonist trigger because all the receptors are internalized. So, but antagonist, what happens is this, it acts on the same receptor but by a competitive inhibition, and it causes immediate suppressive effect. And it onset of action in 6 hours and the duration of action is only 24 hours. So, again, so every day you need to give a antagonist injection to keep it up, right? So, and the suppression of LH is also very good, almost 70%, and FSH is 30%. Usually give the cetodilix, or sometimes we give the ganirelix injection also. I give both of them in the practice. So the candidates for antagonist protocol are poor responders, excessive responders, normal responders, pure male factor infertility, donor oocyte, emergency preservation. But actually you can give it for everyone. It's not like you should not give for any particular patient. You can give it for everyone. Okay. So now there are two types of antagonist protocol, fixed and flexible. In fixed protocol, we start usually antag on the 5th day or the 6th day, irrespective of the growth of the follicles. Okay, and in the flexible follicle, when the lead follicle is more than 14 mm, or if the estrogen is more than 500 milligrams, then you start the antagonist on the 5th day of stimulation. Else you wait. Sometimes even till 6th day or 8th day, all these things will start. So that day you can start the antagonist to knock off the pituitary. Why this antagonist is started late is because until the cohort develops a little bit, until the estrogen is of a certain value, the LH surge does not start. That is the physiology. So, at this point, if you start the antagonist, that is enough. Now, antagonist protocol, we start gonadotropins from the 2nd day, on the 5th day of stimulation, or during a flexible protocol when the lead follicle is more than 14 mm or estrogen is more than 500, you start the antagonist. Give the trigger, then do the pickup, and then do the ET. Now, antagonist protocol, the advantages are prompt control of LH, shorter duration of stimulation, decrease gonadotropin, decrease OHSS, agonist trigger, no hypoestrogenic symptoms, no cyst, etc. And disadvantages is profound LH suppression, strict timing, demands high patient compliance, etc. Now, there is also a mild stimulation IVF when low doses are given for a smaller, shorter durations. And advantages is safe, it's very safe. In poor responders you can use, because anyway they are going to respond to only very low doses also, they will respond the same way. High doses also they will respond the same way. Okay, lower cost. Individualized ovarian simulation is something depending on each and every patient you individualize. That's how we do. We do not give same blanket therapy for everyone. Okay. Now coming to prediction of ovarian response, Again, this might not be necessary for you exam purpose. It is actually to the level of a neat super specialty. So age is a very important thing marker. Ovarian reserve test is very important to predict the ovarian response to control ovarian hyperstimulation, previous response to COH, and female is the most important predictor of live birth rate. Now, starting dose depends on based on age, BMI, AFC, AMH, and previous response to control ovarian hyperstimulation. Ultrasound, the first is done on the day 5 of stimulation to see for criteria. Next ultrasound is done after 2 to 3 days, and follicle grows in the rate of 1 to 2 millimeter, and estradiol per follicle, which is produces 200 picogram per ml, and estrogen progesterone on the day of trigger. Okay. For the response, high responders are in the high risk of OHSS. Prognosis in the subsequent cycle is very good. Okay. And poor responder, 3 or fewer follicles, 16 mm or greater. So there are 3 types of responder: high responder, poor responder, normal responder, depending on the number of eggs they produce. So if they produce more eggs, it's called high responder. Low number of eggs, they are called poor responder. And how to individualize each of them is what is given in these slides. Now, triggering of ovulation, again, this is a question that is asked in the DNB examinations. So, the trigger is you have to have good number of follicles of 17 to 18 millimeter, and few follicles of 14 to 16 millimeter is okay, and serum estradiol of more than 200 per follicle when the follicle is more than 14 mm. The endometrium should be 8 to 9 mm. An injection of usually HCG 5000 to 10,000 is given, or a recombinant HCG 250 microgram is given, or agonist can be used in patients for high risk of OHSS. Then the next important step or the most important step in the IVF process is the oocyte retrieval. So, I would not tell most important, one of the most important, because embryo transfer is the most important step. Oocyte retrieval is done usually 34 to 36 hours after the trigger administration. Transvaginal aspiration is usually done, and as I told you, the transvaginal probe, it is done entirely through the vagina. There is no, you need not actually, you can see the videos in YouTube. There is absolutely no cuts that is given in the abdomen because patients fear, like how you will do the IVF, how you will take the eggs out. It's entirely done transvaginally. Okay, there will be a small probe and there will be a large needle which will go in through in and out of the vagina and collect the eggs. Okay, and the woman undergoing transvaginal oocyte should be offered conscious sedation or under GA, and definitely prophylactic antibiotics can be given. We will give it, but it is controversial. And thorough irrigation of vagina is done with sterile saline. And sometimes we do not collect the follicles because of the wrong trigger or wrong timing of the egg pickup, and so many things are there. But just know the take home point is transvaginal aspiration of oocyte is done with a 17 gauge needle. Okay. So, the complications of the procedure is pelvic infection, hemorrhage, risk associated with IV sedation. No oocyte can be obtained, that as I told you, empty follicles. Rare risk is a laceration of the veins because all the pelvic veins are directly lying below the ovary. Rupture of a dermoid cyst, adnexal torsion, and vertebral osteomyelitis. Okay. And once you get the oocytes, you grade them. You grade them on the basis of, you give it to the embryologist in the embryology lab and you grade them. So, there is prophase 1, there is metaphase 1, and then there is metaphase 2 oocyte. Okay. Prophase 1 or the germinal vesicle is an immature oocyte. Metaphase 1 is an intermediate oocyte. And the mature oocyte which we aim is actually the M2 oocyte. Okay. So, there will be a cumulus corona radiata which will be expanded, presence of the first polar body that will be there. Okay. And it will arrest at the stage until fertilization takes place, and it will complete the meiosis by expelling the second polar body. So, if the second polar body is there, then it means that the meiosis is complete and the sperm has entered the egg. That will happen during IVF, after IVF, or while doing after doing an ICSI. Again, in vitro maturation, it is not necessary. It is just a theory which will be needed. So, sperm retrieval. Now, we have got the eggs. How do we take the sperms? Usually an ejaculate. Once the egg collection is being done, husband will be asked to give the ejaculated sperm in the room nearby, and then we pick the best sperms and do the ICSI for the patient, or we do an IVF for the patient. Sometimes the sperm cannot be obtained by an ejaculation. In such cases, some sperm retrieval techniques can be adopted, such as testicular sperm extraction, microsurgical epididymal sperm aspiration, percutaneous epididymal sperm aspiration, and so on and so forth. Now, going on to IVF, the sperm preparation or the swim-up procedure density gradient method is usually used. Okay, and then the isolated sperm is incubated in the protein-rich media for 0.5 to 4 hours. 50 to 100,000 motile sperms or oocytes are there for an interval of 12 to 18 hours, and in such a environment of 37 degrees Celsius, 5% CO2 and 98% relative humidity, and these are evaluated for fertilization after 18 hours. And the fertilized oocyte will have 2 pronuclei and 2 polar bodies. As I told you, 1 polar body will be present in mature oocyte, and a fertilized oocyte, 2 pronuclei and 2 polar body is present. And fertilization rate is usually 50 to 70% in IVF and higher in ICSI. In ICSI, the sperm is directly injected into eggs and fertilization is checked 17 to 18 hours later. See, this is how they inject the sperm into the egg. And indications for ICSI include severe oligospermia, asthenospermia, teratospermia, pre-implantation genetic testing, PIG, nobody uses now, PGT, it's pre-implantation genetic testing, previous poor fertilization with a conventional failure, and cryopreserved oocyte. But practically, now it is ICSI for, that's how most of us function. Okay, but however, in exams, if they ask, you can definitely tell. If there is a strong male factor infertility, if the sperms are abnormal, they cannot fertilize the eggs by themselves. One of these factors, or the PGT embryo, or it's a poor fertilization, or it's a cryopreserved oocytes, then you can use a ICSI procedure. Okay, so a single sperm is immobilized and drawn into the pipette. Oocyte is entered at 3 o'clock position. Okay, and the polar body is kept at 6 o'clock or 12 o'clock position, and sperm is directly inserted into the ooplasm. Thereafter, the embryo is formed and being cultured in the incubators, okay, with the protein supplements which are there, and there are pre-impaction compaction embryos and post-compaction embryos. So, usually the media is little different for both the embryos. So, till day 3, it is called as pre-compaction embryo. From day 3, after day 3, it is called as post-compaction embryo, and the media also is different. So, we change the media in the lab on day 3 to accommodate the post-compaction embryos. Now, most important thing is extended culture. We do the extended culture. See, cleavage till cleavage stage embryo is day 3 embryos or pre-compaction embryos, and after that you get the blastocyst, that is 5th day embryos or 6th day embryos are blastocyst embryos. That is because blastocyst is better. Most of us do the blastocyst culture because of the better assessment of viability, better synchronization between endometrial development and embryonic development. You can do a PGT on the blastocyst embryos. It has a higher implantation rates, and fewer embryos will be formed, but more potential embryos we will be able to transfer, and we will be able to avoid all the weaker embryos to be in a. If I have to put it in easy words, this is the answer why we prefer a blastocyst culture. Now, assisted hatching, of course, we can use the assisted hatching. Okay, and this is the blastocyst grading system. You may not be asked in the exam, just the name alone you read. Okay, whenever you are in doubt, read the name alone. Okay, and then the embryo transfer, most important step. The goal is to deliver embryos in an accurate atraumatic fashion to avoid the mucus, blood or uterine contractions. For better results, you perform mock transfer in all the patients. Soft catheter is better than the stiff catheters. Remove excessive cervical mucus before the transfer. Examine the catheter microscopically. Transfer media volume less than 50 ml. Catheter tip of 0.5 to 1 centimeter. It should be from the fundus, it should be 0.5 to 1 centimeter, and transfer it under transabdominal ultrasound guidance. Okay, so now usually the criteria for embryo transfer, just know that most of us prefer to do a single embryo transfer only if it is a already tested euploid embryo. Euploid is after the embryos are subject to PGT. Okay, if the embryos is tested and found to be genetically normal, we call it as euploid. So, we usually transfer a single embryo. Okay, cleavage stage embryo, usually it's a blastocyst embryo. So, most of us prefer to transfer a single embryo. But if the conditions are not favorable or the age is increased, then we will transfer 2 or 3 blastocysts depending on the age. Now, after the embryo transfer, we support the progesterone, which is called as the luteal phase support. Progesterone is the luteal phase support, and that is because after the stimulation, what happens is multiple follicles are there, high levels of E2 that will cause a poor sustainability of corpus luteum because, residual suppression of the pituitary LH secretion. So, you have to supplement with the progesterone, which is best is vaginal or injectable progesterone. Oral progesterone does not have much evidence, but luteal, and if you are giving HCG, which will act as an LH surrogate, what will happen is there will be an increased risk of OHSS, which I have in detail explained in the OHSS video. Okay, so pregnancy testing after the IVF embryo transfer is done on the day 16. Thereafter, you do the TVS at 5 to 6 weeks and TVS at 6 to 8 weeks to document the fetal heart rate. And then we'll move on to the cryopreservation. If we are not doing the embryo transfer, we'll preserve the embryos. Usually, we do by a vitrification or rapid freezing, to be very simple. So, what happens is, rapid freezing is, the cellular water is replaced by the cryoprotections and it is stored in a glass-like manner. Okay. So, slow cooling nowadays, everyone does vitrification. Then, going on to, when we use a third-party reproduction, ART law 2023, according to it, we have to screen the donors for infectious disease and genetic disease and take the donors between 23 to 35 years. Usually, do it in premature ovarian failure, gonadal dysgenesis, bilateral oophorectomy, ovarian failure, high risk cases of IVF treatment, and high risk of transmitting genetic disorders. Then, just an additional point about this time-lapse imaging. This is a new incubator that has come. Okay, there will be a rapid sequence of the embryo photos that will be kept, and you can continuously monitor the embryos without even opening the incubator in the screen. So, this uses a technology called as morphokinetic algorithms, calculation about what the embryo should be doing at the specific points of time, and embryos with the highest potential according to the morphokinetics are selected and transferred. So, the first in 2013, a baby conceived in this technology was implanted and the mother has delivered and she is happy. So, as far as IVF is concerned, it is again longer. You still have the ART surrogacy law that will be there in a separate, and fertility preservation is also there. I will club them both and do a small presentation, just exam oriented. So, for ART, this is enough. What is ART? What are the complications of ART? What are the subdivisions in ART, like stimulation part, egg retrieval part, freezing, and then the embryo transfer? All these things you must have an overview and you can write an answer in the examination.